Hi, Be Health Empowered family. This is Dr. Melissa Clarke, and welcome back to another week of Excuse Me, Doctor. Thanks for joining us to kick off the amazing week that we are going to create for ourselves. And, here at Excuse Me, Doctor, we bring you health topics that are based on science so you can be confident and empowered to make the best health decisions for you, your family, and your community. We bring focus to speculation, we clear up misinformation, and we debunk disinformation. We're here every Monday. We stream on YouTube and Facebook. And so I want to especially welcome my newbies. Please remember to hit like if you're joining us on Facebook and subscribe, that red button, if you're joining us on YouTube. So what are we talking about tonight? We are talking about Black women dying in childbirth. It is something that is happening more often than you think, and it happens to Black women more often than any other group. Why are Black mothers dying more often than non-Black mothers? We are going to dig into that tonight. I want you to share this episode right now with all the expectant mothers to be, all the want to be mothers, all the mothers who are ready mothers, and also, most importantly, share it with the people who love them. So please stay really engaged with us during the hour, because I'm going to be bringing on some really expert physicians in this field and a certified doula. And if you don't know what a doula is, stay tuned, because we're going to talk about that. So I look forward to you writing all your questions in the chat, because I know you're going to have a ton of them. And, we're going to take your questions. Remember, that is why we are here, to answer your questions and to empower you. So I'm going to bring my wonderful co-producers into the studio. Lila Mays coming to us from the West Coast. And of course, the wonderful Mr. Wayne Bruce coming to us right here from Maryland on the East Coast.
Hey.
How y'all doing?
Hello. Fantastic. Happy Monday.
Happy Monday. I just want to tell everybody who's trying to get in the studio that you're in the studio already. So it's okay. We'll see you in a minute. How about that?
That's great.
That's what
we have some wonderful guests, and we want to make sure that we're going to be able to bring them to you. So that's what's going to happen. But right now, we're doing our weekly recap. And, as always, we start off with the numbers of people who have coronavirus, because unfortunately, we're still adding to that number. Something like 38,000 people a day are still getting coronavirus, despite whatever announcements that you might be hearing from various government officials. And we're now at 33.7 million cases of coronavirus. Most places, the case count is going down. The new numbers of cases are going down each day. So that's good. Still some hotspots out there. Wyoming, Arkansas, Alabama, and Nebraska are still where cases are going up. And the states with the steepest drops in the daily cases, guess where those are? Those are the places that have the highest vaccination rates.
Come on,
oh, well, of course. Of course.
Come on, vaccinations.
Right.
So vaxes.
So unfortunately, we have crossed a grim milestone of over 600,000 deaths from COVID-19. Again, because the number of cases, new cases every day are going down, the number of deaths, which typically lags about 2 weeks behind that, the trend of the cases, fortunately, that's going down as well. So thankfully, we hope that's a trend that continues.
Yeah, indeed. So, all right, Dr. Mel, cases, death toll, let's get into some facts.
So we're at 271 million doses of the vaccinations given, 122 million people fully vaccinated. New Hampshire, we've been keeping count of who's like out in front in terms of vaccinations by state. So it has been Maine for 5 weeks in a row, but they just got knocked off by New Hampshire. So they have like 55% of their population up in New Hampshire vaccinated. That might be a good place for a summer vacation.
New
And then New Hampshire, that's right. But 14 states have actually gotten at least 50% of their population fully vaccinated. So that's fantastic.
Wow.
Yeah.
Mississippi is coming in last. Only 25% of their population is vaccinated. But even they, at 25%, have had a 30% drop in new COVID cases. So that's pretty good. We're happy. We're happy for them. We hope that they get it on track.
I just want to
let you know. On, MISSISSIPPI.
I just want to let you know. Somebody said it's only 60 people in New Hampshire. So
that's not true.
That's not true. That's not true.
Well, 30 of them, over 30 of them are vaccinated.
They are vaccinated, right. So we got New Hampshire. New Hampshire is leading the vaccination. Mississippi, come on, get your game up. But Dr. Mel, I've been hearing there are people who want to get vaccinated, right? But maybe there are some obstacles. And I think it's important for us to sort of talk about that.
So especially in communities of color, especially among Hispanics, there was this big study that came out from the Kaiser Family Foundation just this past weekend that basically said there are a lot of people that want to get vaccinated. It's not that they're hesitant, but things like working 2 jobs and childcare keeps them from being able to just drop everything and go get vaccinated. They're also concerned about, being down for a day after you get that second shot, with, fatigue and chills and the like, even though it only lasts for a day. If their job is not one where they have flexibility to call in sick, then they're very concerned and hesitant, and I understand, about going to get that second shot. So the thing is, and there's also a fear of immigration issues. There's a rumor that, they're going to ask for ID, and, a lot of times they'll have National Guard standing at some of these mass vaccination sites. So that's scary to a good segment of the population. And so those are reasons why some people aren't coming out to get vaccinated. So we really just have to make it more easy for them.
Yeah. Okay. Indeed.
All right.
Yeah.
Co-producer, you got next?
I got next. So look, we traveled this week, and everybody was excited where we were. It's our first time traveling in over a year. And because they were excited because the CDC has new rules. So you want to talk about that?
Well, yes, I do, because I want everybody to be clear that these rules about no masks indoors and outdoors are for vaccinated people. It doesn't mean that the pandemic is over. It means that the CDC is saying that the science shows that vaccinated people are at very low risk of getting severe COVID and very, very low risk of transmitting it to others. So therefore, it's fine for them to not wear the mask. But this guidance is causing all kinds of issues, because it's one thing to have the science. It's the other thing to have the common sense and think about the way that it's going to affect people's behavior and the way they think about things. So number one, how are businesses going to enforce this? They're not going to be able to go around and ask people, hey, you got your vaccination card? If you don't, put your mask on. It's going to lead to drama and confrontations. The other thing is, I just think that also there's some fine print in there, even for vaccinated people. So when you go to nursing homes or when you go into a hospital, you should wear your mask. If you are a vaccinated person who has some sort of issue with their immune system, like HIV, for example, you should still wear your mask at all times, because it's unclear how much immunity. We know you do get immunity from the vaccine, but you don't get as much as somebody who has a fully functioning immune system. So you should continue to wear your masks at all times. And of course, all the unvaccinated people should still be wearing their masks.
Man, listen, wear a mask. Okay. Well, I can't tell you what to do.
Right.
I can't tell you
as
our
soon as you tell somebody
viewers what to do.
As
I
soon
can't
as
tell
you
what to
tell
do.
somebody what to do, they gonna hold up a Costco. They gonna come back with ask for their Costco.
I can't tell
money
y'all
back.
what to do.
They gonna ask
But
for their
as
Costco
for me,
membership back.
Yeah, as for me in my house, we're wearing masks. I don't know these people. I'm wearing a mask. So
I think
I
that's
don't
a
know,
lot of
Wayne, how
people's
you feel about it, but
thoughts,
yeah, I'm wearing a mask. And if you're around me, I in my house or around my house or around me, my request is that you put a mask on as well.
All right.
That's where I'm at with it.
All right.
I think Miss Lila has spoken.
I have spoken. I don't know how Wayne feels about that, but yeah, if you're around me, we're gonna have some. You gonna have some masks on
get in the studio.
around this tribe right here, right?
Around this tribe.
Exactly. Dr. Mel, listen. This one right here. This is for your girl. Coffee in the heart. Yeah, man. Let's talk about that.
So yeah, it turns out that there was a study that showed that drinking one or more cups of coffee every day can actually potentially reduce the risk of heart failure. But it's only if it has caffeine. Decaf doesn't work. And adding a whole lot of cream and sugar also kind of defeats the purpose. And they figured this out by following over 20,000 people for 10 years. And they saw that the risk of heart failure fell by 5 to 12% per cup of coffee per day. So the more coffee that was consumed, it lowered the risk of heart failure. Now, does it mean that you should only focus on drinking coffee for heart health? Of course not. You should be focused on your fruits, your vegetables, your whole grains, your healthy fats, things that are low in sodium and added sugars. So decrease those processed foods, canned foods, those kinds of things. And of course, stopping smoking, losing weight, and exercising are still really key parts of heart health. So,
all right, amen.
That's it for the coffee.
Speaking,
if my mom is in the audience, yeah, Mom, we doing all right. Let's keep our cup and a half going for this heart health.
All right,
cup and a half.
All right.
So that makes me happy because I like coffee now.
We are some coffee drinkers.
So now, for all those people who are not drinking coffee and still have their blood pressure high, what should we do? So
it turns out that the younger you are when you start exercising, the better. And that if the normal recommended amount of exercise a week is 150 minutes or 2.5 hours. But if you double that and do 300 minutes or 5 hours of moderate intensity exercise, it actually can prevent high blood pressure, which of course, high blood pressure we know is associated with heart attacks and strokes and even dementia. Okay. Yeah, so you got to keep it up until at least age 60 to get the benefits. And it doesn't all have to be aerobic exercise. A couple days a week, you could throw in some weight training, some weights, because weights help bone health, balance, and memory in later years. So shoot for the 300. They had that movie, the 300 workout and all that. So 300 minutes, shoot for that a week, and you can control your blood pressure. Okay.
All right. Yeah, I know you don't want to broach it, my friend. I know you don't. Well, we have to.
It says Ed and COVID. Now,
I don't know who Ed is. Erectile dysfunction and COVID. Okay, right. Let's talk about it, Dr. Mel.
Men don't like to talk about it.
Well, this is important because it turns out if you've had COVID and you're having erectile dysfunction issues afterwards, that it could be due to the COVID. So there was a study that came out. We know that COVID damages the inside of our blood vessels in our body. That's one of the ways that it leads to organ damage. It limits blood flow. So where in the body has lots of blood vessels? The penis.
That thing.
Mm-hmm. So that's for all the brothers who don't want to get vaccinated, and they talk about, I'm going to just ride out COVID. It's like the flu.
No, it's not like the flu.
The flu has never given you ED, brother.
Right.
Just saying.
So the bottom line is, and then they were also able to recover the COVID virus from inside the penis the cells inside the penis long after the infection was over. So it could be potentially a side effect or a long hauler COVID symptom, right? So if you are affected in this way, or your loved one is affected in this way, will be a great idea to talk with your doctor, or especially a urologist, about that issue.
Okay.
Okay.
All right. So that's it for our recap. I want to remind everybody to, start writing your questions in the chat. And then we're going to go to what now?
The weekly debunk.
There you go.
Stopping misinformation in its tracks.
So Tanisha Twitter fingers hit me with this one. Hey, you're using masks will destroy your immunity. I don't wear masks because I heard that it stops you from being exposed to germs that will build your immunity. It's like a muscle. If you don't use it, you lose it.
I don't know about that. Excuse me, Dr. Mel, is this true?
Well, the theory is that masks will stop germs from coming in the body and challenging the immune system, and the immune system will get lazy, and that will reduce the chance of it being able to respond to infections. But there are two major reasons why this is just wrong. Number one, it's based on the hygiene theory, which states that children who are kept in very clean environments have a higher rate of hay fever and asthma, which may be true. However, our immune system, although it's influenced by environment and infectious agents, that really shapes us prior to us being born and when we are born. Those first few months. As we grow up, our immune system grows up too. And so it's not really something that we need to worry about in late childhood and adulthood. And then the theory also assumes that wearing a mask stops all germs or microbes from entering the body, and it is far from it. Anytime you eat or drink or something, you're introducing bacteria, viruses, germs into your body. So, for example, an apple has up to 100 million bacteria on it. Forgetting to wash your hands before eating transfers a bunch of germs into your body. And a French kiss with, your loved one transfers 80 million bacteria from one mouth to another. So masks are not going to keep you from being exposed to germs. Still wear a mask. Practice, proper hand hygiene. And doing those things are the best way to avoid coronavirus exposure. And of course, vaccination is the best way to avoid getting sick if you are exposed. So that's our weekly debunk.
That's it for us.
All right.
So
I want to thank you guys for going through that with us. We are going to move into our show.
Before we do,
Mm-hmm.
Lila's going away.
I am. I have to leave you tonight.
Oh, well, we will see you next week. For all those Lila fans out there, she'll be back.
With a new hat, maybe.
With a new hat. Check Lila's new hat. See you, Li.
All right. See you later, Li. All right. So, we talked at the beginning about the fact that African-American women are dying disproportionately in childbirth. So check this statistic out. A Black woman with a college degree in New York City has 3 times the risk of dying in childbirth as a white woman who only finished high school. Why are too many of our Black mothers dying around childbirth, and what can we do about it? We have 3 incredible experts who are going to be our guests tonight to help us understand what is going on with our Black mothers. And they will also talk about solutions. So I want to immediately bring in my first guest, Dr. Salika Michelle. She is a board-certified OBGYN with over 20 years of experience. She specializes in minimally invasive robotic surgery, and she's delivered over 4,000 babies. She co-chairs the Maryland Health Equity Task Force on maternal mortality. So I want to welcome Dr. Michelle to the show tonight. Thanks for joining us, Dr. Michelle.
Glad to be here. Super excited for the conversation.
Yeah, so let's jump right into it. So you heard me mention that statistic, and we also know that Black women are 6 times more likely to experience complications, not necessarily die, but have really a rough time leading up to birth, during birth, and immediately after. So what is it that our Black mothers are dying of? What's going on?
Wow, it's really, really multifactorial. If I had to pinpoint one area of medicine and just health awareness, hypertension is probably the number one factor that's affecting our mothers. So we
And
know
that's
that
high
the
blood
United
pressure. Mhm.
Yes, high blood pressure. So we
Mhm.
know that the United States has the highest maternal mortality rate amongst affluent countries in the Western world. So when we're comparing our data to the Canada, to the countries in Europe, uh, our patients have the highest rate of chronic illness. They hold the greatest financial burden for healthcare costs, and they're more likely to miss appointments due to cost and inability to access transportation and so forth. But we also know that there are significant risks, increased risk of complications, particularly over the past 20 years, and that's hypertension, high blood pressure, diabetes, or the sugar, as some of us call it, and
Mhm.
cardiovascular disease. And all of those parameters have increased. The CDC has basically said that the rate of maternal mortality has increased almost twofold in about 20 to 30 years. So if we think
So
about, go ahead.
yeah, I was going to say, I just want to drill down when you say high blood pressure and diabetes. What do those have to do with childbirth? I mean, what are the actual
Everything.
diseases that people are dying? Yeah. Explain to us a little bit that connection.
Yeah, so with high blood pressure in particular, it can affect mom and it can affect baby. So if we have a mother who potentially has hypertension, and there have been some data that has said 44% of Black women over the age of 20 will eventually have some form of high blood pressure.
Wow.
That's high. That's high. So if we have a mom who starts the pregnancy with underlying high blood pressure, she has increased risk for developing preeclampsia. Preeclampsia is a disease that affects blood pressure. It can affect kidney function. It can affect liver function. It can affect those cells in the blood that make blood clot as well. And
Hmm.
if it's affecting mom's blood vessels, it can also affect baby's blood vessels, or the vessels that go to the baby in the placenta and so forth. And with that underlying effect, it can increase the risk for placental abruption, which is the placenta separating from the uterus prematurely. And
Hmm.
with all of these parameters going on, that compounded by any potential obesity or anything like that, it is making our moms enter pregnancy sicker as
Wow.
compared to our white counterparts. So I think if
Got
we
it.
can at least correct the health care for our moms prior to getting pregnancy, we can eventually decrease the risk of our maternal health mortality and morbidity, and our
Sure.
overall health outcomes going forward.
So you mentioned improving health of people before they get pregnant. What are some of the factors outside the healthcare system that lead to Black women having higher rates of high blood pressure and diabetes?
Stress is number one, really. Black women are notorious to have more stress as compared to their white counterparts, and that's stress from systemic racism, that's stress from their jobs, multitasking, and just a genetic predisposition just for hypertension. As I mentioned, 44% of our women are going to have some element of hypertension. There's got to be some genetic element. But with regard to managing the high blood pressure, I think what we're going to need to do is have some intercollaborative efforts between specialties to really get our moms into their best selves prior to getting pregnant, so that we're not necessarily dealing with the potential complications of them being unhealthy getting into the pregnancy. But aside from health itself, we know that we have our white counterparts who also have hypertension, but for some reason they're not dying like our Black moms. And so there are other parameters with regards to access to health care,
Hmm.
access to insurance,
Right.
transportation to get to the appointments, having a support system. And with the pandemic going on, a lot of our moms just haven't had access to their village, their traditional village. And I think now is a time where we really, really need to increase our ancillary health staff to really pour into our moms in the forms of doulas or other support persons that can help make our moms antepartum course while they're pregnant a little
And
bit more.
antepartum means before you give birth, right?
Yep, while they're pregnant. Yep,
Yep.
the antepartum course while they're pregnant, and versus in addition to their postpartum course after they're pregnant,
Right.
to give a voice to the moms. And
Sure.
we're going to be talking to about doulas going forward. But I think in our practice and at our hospital, doulas in particular are going to be playing a much larger role in the healthcare of our mothers.
So I'm glad you mentioned doulas because I want to bring in our next two guests. First of all, I'd like to introduce to everybody the wonderful Dr. Yolandra Hancock. She's a mom, she's a pediatrician, and a public health shiro committed to raising the next generation to reach their full health potential. She's also a professor at George Washington University School of Public Health, and she is the founder of Delta Health and Wellness Consulting and a consultant to the Prince George's County Council when they sit as the Board of Health. Welcome, Dr. Hancock. Thank you so much for being here.
Thank you, my soror. Thank you for having me in this space.
Absolutely. And I did not mention she named her consulting practice Delta Health and Wellness for a reason. So yes, thank you, Sora, for being here. And then next we have Dr. Tessa Stecker. She's program director for both the Kaiser Permanente Northern California Community Medicine Fellowships, as well as their resident health policy elective. She works with medical students, residents, fellows, and her interests include community medicine, global health, adverse childhood experiences, which she's going to talk to us about tonight, implicit bias, and anti-racism work. And she serves as the adverse childhood experience physician champion for her medical center. So thank you so much for being here, Dr. Stecker.
Thank you so much for having me. I'm excited for this conversation.
Absolutely. So let's start. Actually, I was going to start with you, Dr. Stecker, but I want to go first to Dr. Hancock because we were just talking about doulas. So I want to kind of pick up on that thread. And Dr. Hancock, you're a pediatrician, but as a mother of a beautiful daughter, you have a story to tell about what happened to you around the time of her birth. So tell us that story and how it's affected your decisions professionally going forward.
Sure. So in my last trimester, about 2 weeks before my daughter was actually due, she stopped moving. And I was, throughout the pregnancy as a Black woman, I was continuously concerned about how I would survive through having a baby. It took a lot of effort to get pregnant. And as I delivered her, one of the happiest moments of my life, the day after that, I had a hypertensive crisis. I literally felt like I was going to die. And that's what I communicated to my nurse. My blood pressure was 200 over 110. And I ended up on blood pressure medication for almost 6 months after having my daughter. I had never had a blood pressure higher than like 115 my entire life. And, throughout the pregnancy, it was so difficult, a lot of stress. I dealt with micro and macro aggressions as a Black woman working in a predominantly white institution, overworked and underpaid. And I was having relationship issues and I didn't reveal it to anyone. I felt as a Black woman, I would just sort of meditate and pray my way through it. And I wish that I'd had a doula, but, being a pediatrician working out in the inner city, and with loans to pay, I didn't have the money for a doula. And unfortunately, insurance didn't cover it. And because of that, and then the continuous loss of Black women across the country, it really pushed me. I've always been interested in natural ways of healing, learned a lot from doulas and midwives when I was in medical school, and made a commitment in 2020 after we lost one of our sisters in pediatrics. A pediatric resident lost her life soon after having a baby just last year. And it's what compelled me. And then finally a mother asked, she said, if I have a second baby, the only way I'll do it is if you serve as my doula. And when she asked that was what sealed the deal to facilitate me becoming a doula.
Wow. So tell us, I mean, first of all, it's amazing that you, had that complication with that high blood pressure. But tell us, what is a doula? What do doulas do?
So a doula serves as an advocate. A doula serves as a coach as a mother continues through pregnancy. My vision for becoming a doula was really to connect with a woman from the time she finds out she's pregnant all the way through until after she delivers, so that I have the ability to assist her through that process and to really just be there for her, to make sure that I understand what her vision is for her birthing process, how she sees her role, the role of her partner, and I'm just there to facilitate it. Certainly as a physician, I have a different perspective because I can communicate and advocate in a way that most doulas cannot. What I found in my training is that it can be very contentious and adversarial. I hear conversations in the doula circle about OBGYNs. I hear circles in the in the physician circle about doulas. And my goal as both is to sort of help bridge that so that I can advocate for mothers, but also have each side of that care continuum have a clear understanding of each other's role and how we work interprofessionally.
Great. I mean, being that bridge is so needed, and I love your vision. And since we're talking, you're a pediatrician, so that brings up children. And I want to go to Dr. Stecker next because Dr. Stecker, you study something called ACEs, and no, they are not the Ace of Diamonds or anything like that. It stands for Adverse Childhood Events. So can you tell us what those are and how they relate to maternal mortality?
Absolutely. So adverse childhood experiences are essentially traumatic experiences that people experience before the age of 18. So sometime in childhood and before the age of 18. And the reason why these experiences are important, there are three categories of experiences: household dysfunction, neglect, and abuse. And what we know now in studying these three different categories is how pervasive they really are in our society. About 60% of the American population will have had at least one adverse childhood experience before the age of 18, and about 1 in 6 Americans will have 4 or more adverse childhood experiences. Now, you would assume in hearing about these adverse childhood experiences that they would affect you, particularly as a child and maybe as an adult, in terms of your mental health, in terms of your predisposition for depression and anxiety, or your predisposition to try to deal with the trauma that you've experienced in perhaps some unhealthy mechanisms such as substance misuse. But what's surprising to a lot of people is that these adverse childhood experiences also affect you medically. They affect your predisposition for chronic diseases. They affect your predisposition for certain cancers. And in the case of maternal health, they increase your chances of premature delivery, of fetal complications, and of maternal death. So these are experiences that are pervasive and that have long-lasting consequences, and especially in maternal health, because these experiences are disproportionately affecting women in this country. And when you layer race and ethnicity on top of it, those same groups of people of color in this country that have disproportionate outcomes when it comes to heart disease and stroke and cancer also experience a disproportionate number of ACEs in their childhood, and therefore more complications going forward.
Wow, that's just, we know about the mind-body link, but that just takes it to a whole nother level, right? When we do experience these things as a child, what is happening in our bodies physically when we don't have the coping mechanisms to deal with these neglect, abuse, and other traumas that we experience as a child? What's happening in our body that then leads to these issues later in life, these health issues later in life?
It's a great point you bring up, because this actually takes us back to the fact that when we're talking about maternal health, we're always talking about a dyad. We're talking about mom and we're talking about baby. And in the case of ACEs, they affect both parties. So what happens when you experience adverse childhood experiences and you're not buffered with resilience, where you don't have some protective mechanisms in place to help to reset you, is that you're living in the condition of chronic stress. So imagine, for instance, being in a war zone, but being in a war zone constantly. And so you're ever vigilant and you can never turn that off. And then what happens is that your body gets used to being in this constant state of stress. And so you've got your cortisol stress hormones that are always high, and you have trouble sort of deregulating and getting sort of back to normal. And in addition to that, this chronic stress leads to chronic inflammation. And chronic inflammation is basically the underpinning of most disease processes that we see. And so we know that chronic inflammation plays a role in chronic diseases such as high blood pressure or diabetes, but it also plays a role in adverse outcomes when it comes to maternal health, maternal mortality as well. And so this chronic stress and trauma actually helps to reorganize the brain. It actually changes brain development. And when you're talking about infants in particular, they have immature stress response systems. And so they are ever more vulnerable to mistreatment, neglect, maltreatment affecting their stress response and affecting their ability of their body to deal with stress in a healthy way to help prevent some of these outcomes in the future. So it really on multiple levels really changes the body's chemistry, which is startling, but is an important thing for us to know as communities and as healthcare providers as well.
Absolutely. So I'm going to go back to you, Dr. Michelle. Are OBGYNs incorporating any of this kind of information or into their practice? Or if not, what is happening in the OBGYN community in recognition of this increased risk for Black mothers?
I can speak for my practice and definitely my hospital with an initiative that it really is designed to create an atmosphere of cultural competence so that our patients can have more positive experiences and satisfying services. And once our patients begin to have that, they're more likely to continue to have to continue to try to seek health care, particularly our moms. And we know that mothers kind of dictate what happens in the household. So if we can get our moms feeling very comfortable with providers and health care, they're more likely to have their children going to the doctor and have their partners go to the physician as well. So because we know that the women are leading in the household, we really need to target creating positive health outcomes, positive health experiences for our mothers as well. And for our OBGYNs, at least now, we are really looking to not necessarily level the playing field, but kind of increase the players on the playing field to create a team to have our patients have advocates and a sense of advocacy for their health care. So we are incorporating a lot of different avenues, different programs in our hospital, but also tangible components with doulas, with breastfeeding assistance, with targeted assistance for insurance coverage for different items, and really figuring out a way that we can help them even financially with transportation and so forth. And now we're trying to move forward to expand from a government perspective so that we can get some of these services covered for them. You know, not everyone has the finances and access. And services like doulas, which we feel are really valued and valuable, are right now, they're out of pocket expensive. Yeah. And so they're very difficult to access to some. And so we want to have equitable access for our patients. And so that's what we're trying to do.
So Dr. Hancock, as a doula, I know that there's some advocacy work, that you do with the patient, but tell us also about your community advocacy work to address that very issue that Dr. Michelle just brought up about, being able to afford doulas.
Absolutely. I have the benefit and blessing of working with local elected officials out here in DC and in Prince George's County. Councilwoman Christina Henderson out of the District of Columbia introduced the Maternal Health Resources and Access Act of 2021 just this year. which would allow for three things. One, funding for doula services to be reimbursed by Medicaid. The second is transportation, so that moms have the ability to be transported to their healthcare providers, their OBGYN visits. It's a shame that east of the Anacostia River in the District of Columbia, where the predominance of African Americans live, there is not a single hospital that offers obstetrical services. I actually used to work there in the labor and delivery unit, taking care of the babies in the well baby nursery, and fought hard for them not to close it. But here we are. And it's not anticipated that there will be additional services until likely 2023. So the third component is doing a feasibility study to assess the viability of having a birthing center. The only sort of eyebrow I raised was, we don't need a feasibility study. We know what needs to happen east of the Anacostia River. Bring the money on so that Black mothers have equitable access to obstetrics and babies have access to top-notch nursery care.
Right. And getting Medicaid to be able to cover some of that. But I mean, I think, we're seeing these maternal health outcomes for Black mothers happen regardless of socioeconomic status. So, Dr. Stecker, if you can tell us, how are you incorporating screening for ACEs into your practice and what you do every day? And when you do find them, what do you do?
It's a great question, right? And I think that's the one that a lot of providers want to know too. Like, am I going to open up this can of worms by suddenly asking these 10 questions that are traditionally not questions that we've asked in medicine? And that's been part of the problem, because of the fact that these are things that are so pervasive, but they're couched in secrecy in our communities and people don't talk about them. And so sometimes when I ask somebody for the first time, did somebody ever speak to you in a way, or consistently speak to you in a way that was demeaning? Or did you have a parent who was out of the household, or that you did not connect with, or was not part of your life growing up? This may be sometimes the first time that they're really exploring this, thinking about it, reflecting upon it, and the first time that they're doing it in a medical center. And so I think that part of it is just normalizing asking the questions, and so that we can destigmatize and take away the shame from these experiences, because these are all experiences that happen to us. They're not experiences that we have brought upon us. And so I think that we really need to, as a medical community, do that. And so what we're doing in our clinics right now, we've been running a few pilots in women's health, in our centering pregnancy group, in our adult and family medicine, and some of our pediatric specialty groups, is asking these questions routinely to our patients, and having it be something that we introduce the same way that we introduce asking about intimate partner violence, having people answer the questions. They don't have to share the details of which questions that they've answered positively, because what's important is the number. We know that the more ACEs that you've had, and particularly when those are not buffered with resilience or protective factors, the increased risk that you have of certain conditions. Now, this doesn't mean that you had these experiences and you will have these certain outcomes, but we want to be aware that you have a predisposition so that we can offer you the services in order for you to buffer against that. And when we're talking about moms and their babies, one of the things that we've been doing is really thinking about parenting classes and resources when we identify people who have had a lot of ACEs, because we know that this is a time period where people are very motivated to be well and to be healthy, because it's not only about themselves, but it's about the baby as well. And they really want to think about what are the ways that they can put some things into action now that are going to make life better for their baby that they're bringing into this world. And one of the things that they can do is identify these ACEs and then think about some really specific strategies. So there may be behavioral health options, health education options, there's a lot of community options, parenting resources, and a lot of people don't actually need additional resources. Just by asking the questions and having that conversation and normalizing it takes a huge boulder off of their shoulders that they've been carrying around for their entire lives. And we've seen in studies that even in people who have just been asked the questions without any intervention, there's a decrease in the use of frequent ED visits and utilization of the emergency services, that there's decrease in the need for services because of the fact that they've already sort of let go of something that they've been holding on to for so long.
And I would imagine too that if somebody trusts you enough to confide that in you, then they're building a bond with them that's like Dr.
Absolutely.
Michelle said, is going to create an atmosphere that makes them want to come back for services. So, you know, we have had such a fantastic conversation so far. I almost forgot that we have to stop and bring the audience into this conversation. So, co-producer Wayne, are there any audience questions that we need to entertain?
Well, there are quite a few questions, and quite a few questions across the whole show. But I would like to say this first before we start in with the questions. I'm the only man here, and I'm here because I believe we have a responsibility as men to protect our queens, our future queens, and protect our family. So it's very important that men get into this conversation too. And now I'm going to move into the questions. I'm going to lighten it up.
All right, now.
Get too serious on you ladies. But and we have quite a few men watching. We have some men who have questions, but I want to go to a few questions. One, you answered quite a few of them, but we have one from our very own Valerie Spalding Parker, and her question is there anywhere where we can find a list of the ACEs you screen for?
Dr. Stecker?
Absolutely. That's an easy one. If you just type in adverse childhood experiences, CDC in your internet search browser, it will come up. It's a 10-item questionnaire. There's some slightly different versions of it. There are some that are for adolescents or teens, for kids that the parents answer on behalf of the kids, and for adults, but they all essentially ask somewhat similar questions in terms of those 3 areas of neglect, abuse, and household dysfunction.
Fantastic. We have another question from Yvonne Smith. She asks, Medicaid, she makes a statement and asks a question. Medicaid is changing in Washington to managed care. Many things need to be in the benefit package. What else besides doulas benefit mothers?
Dr. Hancock?
Sure, I think that's an excellent question. Nutritional support is going to be key. Other healing modalities like yoga, meditation, everything that people consider sort of granola. I mean, I'm from Louisiana, but I grew up in Southern California, so everything I do is sort of Southern granola-ish. But it's all of those things that people classically define as alternative treatments, right? I'm a Reiki healer, so I believe Reiki should be covered under Medicaid so that all of these services are equitably dispersed, and everyone who decides that they want to seek out a Reiki healer, and right now acupuncture is actually covered under private insurance. Why not allow that same service to be covered under Medicaid? Everything that I get under my private insurance, gym membership. I taught Zumba when I was pregnant, and I had pregnant mothers in my class. I taught it for free. So all of those things should be covered so that Black women, all women, can reach their optimal mental, physical, relational, and spiritual health and not have to worry about paying for it.
And if anybody is wondering about what Reiki is and what acupuncture is, they can check out my book, Excuse Me, Doctor. I've got what? There's a whole chapter that I devote in there to holistic therapies and what actually works well for what. So check that out. And then Dr. Michelle, is there anything you want to add to that answer?
No, I think all of that is huge. Any type of holistic or naturopathic assistance in healthcare is valuable. I know for us, we use a lot of chiropractors when patients are pregnant for a couple of reasons. One, for just simple back discomfort, hips out of line, but we also use it for our patients who are breech. Our chiropractors have techniques to spin babies. So there are ways to have a chiropractor covered and save on the cost and the inconvenience potentially of a C-section. So these kinds of things really should be under that umbrella of coverage. And I think once we are able to shed light on the value that they bring to the healthcare and how they can potentially be decreasing the cost of healthcare overall, hopefully we'll be able to turn the tables on some of these things.
And I think one last thing, Medicaid only covers the first, I think, 3 months postpartum after you deliver, but there are some things that are results of pregnancy that can last up to a year. And so extending that postpartum period to be a full year under Medicaid, I think is pretty important.
Absolutely.
Okay, we have
particularly for mental health care.
Yes.
Okay, all right, all those things. So we have a question from, and I don't mean to make light of it, but I mean make light of most things. So we have a question coming from Alethea Hughes. Are vaccinations safe for kids between 12 and 15, Dr. Clarke?
Okay, yeah, I'll be happy to take that. So the same studies that were done in adults were done in kids aged 12 to 15 by Pfizer specifically. We don't have data on any of the other vaccines. And so we do know that they received emergency use authorization. And I think it's important to keep in mind that they're overwhelmingly safe and effective in all those age groups. I think there's a lot of concern that people have regarding the vaccine and fertility, for example, or will it alter DNA? And so when you're making those decisions for your child, you're taking them especially seriously. But again, as we've talked about on other shows, the fertility issue is a non-issue essentially. It comes from a lot of different social media concerns around. Does the virus alter the DNA of the egg and does the vaccine alter the DNA of the egg and the sperm? We know that messenger RNA does not get into the same compartment in the cell as our DNA. And we also know that it self-destructs after, like Mission Impossible, after a few minutes to hours in the body. So there's no way that it can actually do that. It does not attack the lining of the uterus in the protein that glues the placenta to the uterus. It doesn't do that. There were many women who got pregnant during the study. At least 23 women who got pregnant during the study didn't have any problems. There have been 35,000 women in the vaccine database. And we do know that they have not had any increases in any complications associated with childbirth and the perinatal period. So again, those concerns for children and future fertility don't seem to be borne out.
Okay. We have another statement and a question. The statement comes from Jojo D. Spruill. Maternal morbidity and mortality is such an important public health issue. She strongly believes that bias in healthcare is the determinant for whether the outcome is positive or negative. And we have another question, and we have a few questions like this.
Well,
go ahead. Go ahead, Dr.
No. Oh, are the other questions similar to that one that you just asked?
A little bit. Somebody
Okay.
said, what the heck does a college degree have to do with anything?
Okay.
Why does a college degree? Why are you saying
right?
That?
Because So
Okay.
I'll comment on that, and then I'm going to go to Dr. Michelle to answer about the bias. So oftentimes education is associated with something called health literacy, which is the ability to take information and make health decisions for yourself. And so oftentimes we see that the more education people have, the more health literacy they have, and the better they do in the healthcare system. So that's why that statistic that I quoted about Black women with a college degree dying more often than a white woman with a high school degree is pertinent, because one would think that as you get more education, you get more income, you're able to afford better care, you're able to navigate society, you have more social capital, and therefore you can make decisions for yourself that advantage you more easily. And so again, that's why it's very surprising that education doesn't seem to make a difference with this particular outcome. But Dr. Michelle, can you talk to us about bias in the healthcare system and what role that might play?
Yeah, just to kind of piggyback on your comment, Black women are still dying regardless of education. Right. So I think that's what she was trying to share. So I have the same risk of dying having a doctorate degree as my grandmother who has a 5th grade education. So the fact that education doesn't even really play a role in the increased risk of Black mothers dying is key. So there's something else going on other than just our educational background. So I think that's what she was trying to share. But with regard to bias in the process, Bias comes from a few different angles. It could just be kind of implicit bias, and that we'll see a lot in our practice of medicine, in addition to systemic bias. So we're differentiating things based on some stereotypes that people come into medicine with, and that could be from how they were raised, how they were educated, and they take those beliefs and biases, and that governs how they provide care. And when it comes to Black mothers, it is hurting us. It's hurting us. And so now we're trying to have specific targeted initiatives for providers from all specialties that have any involvement with our Black mothers, so that they can start to see their care through our lens. And so hopefully that will increase the safety for our moms. And then the other biases that happen, whether it's from governmental, from national, or what have you, those also play huge roles, particularly from access for our mothers. And that's a whole other conversation. We could have a whole talk on this. I could go into details on that.
I'm thinking
Oh my
we might have to
goodness.
have a part 2 of this conversation.
Yes,
There is so
just
much
on
to
bias
unpack.
itself, because that
Yeah.
Oh, yes.
it's powerful. It's powerful.
I think with all the questions, you might have to have a part 2 of this,
Mhm.
and
Yeah.
also we have questions about older women in the healthcare system, and also older women with fibroids. I know that isn't this show, but stay tuned. Stay tuned.
Okay, well, I think we're going to have a part 2 to dig into some of those issues, because I want to. Unfortunately, we only have a couple minutes. I wanted Dr. Michelle to talk a little bit about the Momnibus bill. We heard about the bill in Maryland. Was that Maryland or DC? I'm sorry, Dr. Hancock.
DC.
Sorry. So we heard about the bill in DC, but there's something going on the federal level. So Dr. Michelle, can you break that down for us?
Sure. So the Black Maternal Health Momnibus Act is composed of 9 individual bills, and it's sponsored by the Black Maternal Health Caucus members, and it's really spearheaded by our own Vice President Kamala Harris. And it has 9 specific elements. The first of which is making critical investments in social determinants of health. So access to housing, housing for moms through HUD, and funding some of those programs. Transportation, allowing WIC to extend their eligibility. Right now, WIC eligibility is only six months. They want to extend it to 24 months for the postpartum period, and 12 to 24 months for the breastfeeding period. It is also increasing funding for community-based organizations that improve maternal health outcomes for moms. It's targeted funding for programs affecting our women veterans, particularly those that have mental health concerns. It's providing funding to diversify the perinatal workforce. So we talked about incorporating our doulas and having that as a covered service, so that we can ensure that all of our moms in the United States can have maternity care and support from the people that they truly trust and can be their advocates in the process. We want to improve data collection processes and quality measures, and invest in maternal mental health care, particularly for our patients that have substance abuse concerns. Improving our health for our incarcerated women, providing doulas in prison as well. Training correctional officers to be culturally competent also. Investing in digital tools like telehealth. That was really, really huge in providing care. Who would have thought that I would have been able to provide OB care through telehealth? But the pandemic has shown us otherwise.
I saw a hilarious meme about that. But anyway, that is quite a comprehensive bill. And thanks for breaking that down for us.
Yeah, and also providing incentivizing payment models through the insurance companies, so that insurance companies will be incentivized to have these ancillary services to decrease potential more costly things like C-sections and so forth. So hopefully this act kind of hits the ground running, and it has a lot of support, and it has a lot of really good options and
Yes.
opportunities
Thank you
for us
so
to
much.
decrease our health
I
disparities.
unfortunately have to wrap up. Thank you
Okay.
all. You were fantastic. And I'm serious about having a part 2. So keep your calendars open. I'll be calling. And I want to thank my audience for tuning in once again. We heard so much, but I think it's really important to remember, number one, as we sign off, you see scrolling across the bottom the ways to support that Momnibus bill that we heard about. You can tweet about it. You can call your congressman and advocate, because really we're talking about the life and death of Black moms, and also individually reflecting on those issues that we have and seeking mental health for them, because they do end up registering in our body as ill health. And so that's really a key part of being health empowered. Thank you so much for joining us tonight. Remember, I'll be on the Russ Parr Morning Show tomorrow morning at 8:50 a.m. East Coast time for anybody who can tune in. And if you can't tune into that, catch me next week right here, 9 p.m. Eastern, 6 p.m. Pacific on YouTube and Facebook, Dr. Melissa Clarke and blackdoctor.org. Thanks for tuning in. Until I see you.